Well, hello, and thank you everyone for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, Overview of the SAMHSA Crisis Now Model 988 and the Georgia Crisis and Access Line. My name is Emily Moore, and joining me in moderating today's webinar event is Dr. Benjamin Druss, Director of the Southeast Mental Health Technology Transfer Center. Please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also note that our center and the larger MHTTC network use affirming, respectful, and recovery-oriented language in all of our activities. A few words about our center before we get started. The Southeast Mental Health Technology Transfer Center is proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. We encourage you to visit the Southeast MHTTC website, mhttcnetwork.org/southeast, to learn more about our center and upcoming events. We also have a new data visualization map to accompany this event on suicide and crisis services. We are going to put the link to that new data visualization map in the chat so that you can view it at your convenience. A few important notes to review before today's event. This event is being recorded and will be made available on our website for on-demand viewing soon. We encourage you to share your comments throughout the presentation using the chat feature. Please remember to select Chat with all attendees if you would like to share your thoughts with everyone. We have allotted time at the end of the presentation to answer your questions. Please submit your questions using the Q&A feature at the bottom of your screen. Finally, for any participants who are interested, a certificate of attendance is available for download after completion of our evaluation surveys. I'm going to hand it over to Dr. Benjamin Druss so that he can introduce today's first speaker.
Thanks so much, Emily. So we're really excited today to have 2 speakers. We're going to be hearing from Sue-Ann O'Brien, who is the CEO at Behavioral Health Link and Executive Vice President with RI International, which are 2 leading contributors to the development of the National Action Alliance for Suicide Prevention's Crisis Now, Exceptional Practice Standards in Crisis Care. Together, these 2 teams deliver a full continuum of best practice crisis services powered by customized software and technology solutions and real-time access to mental health and substance use services, diverting thousands from hospital EDs and justice systems to care in communities throughout the United States. After that, we'll be hearing from Michael Clays, who's the Executive Vice President at Behavioral Health Link. Michael is the developer of one of Georgia's first crisis centers, an expert in quality review, and in provider training, provider profiling, and integration of individualized recovery services. Welcome, Sue-Ann and Michael. We're so excited to be hearing from you here today.
Great. Thank you so much, Dr. Druss. I'm going to go ahead and share my screen, and we will jump right in. Get that started from the beginning. Everybody seeing that okay? Yes. Great. So thanks everybody for being here today. I'm going to give an overview of current crisis developments nationally and then also locally here in Georgia. I'm going to start with talking a little bit about the SAMHSA Crisis Guidelines, this new national framework that's been put forth around crisis care. I'm going to introduce the idea of 988. Some of you may or may not have heard that or have questions about what that is, how that's going to be implemented, how it's different from the framework that we have now. I'll talk a little bit about that. And then I'm going to hand it over to Michael, who's going to talk specifically about the work that Behavioral Health Link is doing in Georgia related to the Georgia Crisis and Access Line and some of the crisis innovations that that company has been doing over the years. So we all know that for a long time, we have known how the system works for our physical health crises. If we're having a heart attack, a stroke, any kind of emergency medical issue, since the 1960s, we've had 911 to call. It's been one number that really allowed us all to access immediate care and receive an immediate response to care in that kind of emergency. We have not had that same kind of response on the behavioral health side. So what has typically happened? And every country, or I'm sorry, every county, every state, even city across the nation does things a little bit differently. And what that means for all of us is that it's not a very systemized, integrated system of care. So in a traditional community crisis flow, this is just a graphic that shows you a little bit about what that looks like. So you have everybody, when no one knows where to go, and when there aren't multiple options, everybody goes to the hospital ED or they call 911. Police, if they pick somebody up on the street and they think they might be suffering from a mental health issue, there's nowhere to go, they just take them to the hospital ED. Individuals, families, friends, if you don't know, sometimes in this country, it's your crisis hotline is still dictated by your zip code, by your county, even by the side of the street you live on. And a lot of times when families or a loved one or yourself are in a mental health crisis, how do you know where to go to find that number? It's a fragmented system. You're in a panic. It's a crisis time. You just call 911. And usually you are getting the response of police or fire or ambulance, and you're going to end up at the hospital ED. Primary care and social services, same thing. If there's a concern about a medical issue or even a behavioral health issue that they can't quite pinpoint, they're going to send you to the hospital ED for medical clearance. We're all familiar with that as well. Crisis call lines, if we get somebody in the middle of the night and we don't have a call center hub that can connect people to the appropriate type of care, and we're worried about safety and we have no other options, we're going to refer those folks to the hospital ED. So then, and same with mobile outreach. So you can see you've got all these, when you don't have a centralized point of access to crisis care, and when you don't have a full continuum of care that's known to all and it's easy to understand and it's highly accessible, everybody's calling 911 and everybody's going to the hospital. What happens is the bottom half of this slide, post-hospital, you're either sent to an inpatient psychiatric hospital. Maybe you're given a phone number to follow up and make yourself an appointment at an outpatient clinic later on that week. Or maybe you're just discharged and you're cleared as safe or no medical issues or no harm to self or others, and you just get discharged with no linkages to support. So this is kind of the system that we've been in for years and years and years, and why there's really been a push nationally to try to do something a lot differently with that. Obviously, emergency departments have felt just an enormously increasing burden around having behavioral health folks served in the ED. Not only is this not the appropriate type or amount of care for the person in crisis, it affects other people in the emergency department, it affects hospital staff, and at the end of the day, those folks are just not getting the care that they need. The term that we've been using out there is a clinical fit to need. So making sure that whatever issue the person is presenting with, that we match them up with the right type and amount of care, not providing too much, not going to the emergency department or a psychiatric hospital for something that could be handled on the phone or through a mobile crisis team, or vice versa. So there's been a huge push with the increase in demand on emergency departments, the drain on police resources as well. And then there's associated cost. In addition to not having positive mental health outcomes by going to the ED and having police involvement, there's a huge cost available. And in the end, no one wins. And so this is how several years ago, the National Alliance for Suicide Prevention, NASBID, SAMHSA started thinking about how would we map a way forward to a less fragmented system of behavioral health crisis care. And should that level of care be on par with what we've all come to expect on the physical health side? So in July of 2020, really huge step forward in terms of decreasing fragmentation. It's the first time that a national framework has been put forth. Up until this time, every state, even individual counties, like in California, there's 59 different counties. Each one of those, it's a county-based system. So no matter which county you live in, your behavioral health crisis system is different county by county. So a whole lot of fragmentation, folks not knowing where to go to get help for themselves or a loved one or a neighbor. And so for the first time, SAMHSA said, we need to put forth some set of national guidelines. And through a host of innovations that have been happening over years, some best practices have really emerged. We've had some huge innovators in the field that have a proven track record for a great crisis system, and they kind of pulled all that together into this report. You can find this online. At the bottom of the screen here is crisisnow.com. If you are not familiar with that website, I would encourage you to head on over there. It is rich with all kinds of tools, resources, articles. I'll go into what's on the site a little bit more in a minute, but very rich place. But this is one of the places where you can go to crisisnow.com and just download the national guidelines. I'm going to summarize essentially what the guidelines put forth. They put forth a national framework that's really in three buckets. They promote a 24/7 call center hub, mobile crisis outreach teams, and crisis receiving facilities. So we like to assign language that's someone to talk to, someone to come to you if you're in crisis, and then somewhere to go. Imagine calling 911 and there's no ambulance to come to you, or there's an ambulance to come to you, but there's no hospital ED. That's a little bit of what we have in behavioral health right now. We have this kind of patchwork kind of framework across the country where we don't have that full continuum. So I'm going to go through all three of those and give you a sense about what what's happening now currently, what the minimum standard would be according to the SAMHSA guidelines, and then what we're striving forward in the future in terms of the gold standard. So the someone to talk to is really these call center hubs. We call them hubs as opposed to just crisis hotlines or crisis call centers, because the idea of the hub is that you're actually connecting people to care. You're connecting them to their next step in their journey. It's not a call center where you call, you chat with somebody, they say, sorry, you're going through this. I know it's 3 o'clock in the morning and you're really white knuckling it right now, but here's 3 numbers. When those clinics open at 8 a.m., give them a call and see if they can get you in, and good luck with that. We put the ball back in the court of the person that's in crisis. If you don't have a call center hub that can make those connections over the phone, that's basically what you're doing. You're doing some kind of an intervention to de-escalate the person, and you're giving referrals that then the client in crisis themselves has to follow up on. So the very minimum expectations set forth in the SAMHSA guidelines are to be open 24/7. We do have call centers in this country that still do not operate 24/7, 365. They've got to have some level of clinical oversight. There has to be a basic assessment of suicide risk, preferably having the Columbia embedded in that suicide risk screening. And if you're a National Suicide Prevention Lifeline Center, they've provided you with a host of tools on how to appropriately assess for risk. And then have mobile teams and facility connections. So as I said, be able to engage a mobile team while you've got the person on the phone. You can be calling a mobile team to say, hey, I'd like you to go out to this person's house. I can't de-escalate this situation over the phone. They need a little bit more. I'm not sure what's happening in the home right now. Can you go out and assess the situation? They need a face-to-face visit. And also being able to make those connections to a facility. So if you know that a person is not safe and needs to be in a safe place, a 23-hour observation or a crisis receiving facility, being able to make that connection. The gold standard of the crisis call hub is what we're all kind of striving forward nationally. That's what's underway right now. That's having caller ID so that we can reach the person if we get disconnected, having a GPS mobile team dispatch so the call center can actually see where the person I'm talking to is on the phone and where are all the available mobile crisis teams, who's closest to that person, who can get there in 30 minutes or less, who can get there in 60 minutes or less, et cetera. Having a live bed registry, meaning I'm a therapist, and I think many of you on this call are therapists as well. I remember the old days when I had somebody in my office that was not safe and I wanted to find a bed for them. They basically stayed with me in my office while I called facility after facility saying, do you have a bed? Do you have a bed? How long will it be before you have a bed? And there was no integrated system. So a live bed registry would allow the call agents at the call hub to actually have a view of all of the bed capacity in your area or your region and see which beds are available, and ideally allow the call center agent to go ahead and place the caller into that bed. So again, it's the idea, the hub is this idea that we connect people to care. They've called us on the phone at the call center hub, and we are not letting them go on the other end until they have their next step in place. They know what their next step is before they even hang up the phone with us. Likewise, being able to schedule an outpatient appointment, same kind of thing, being able to have very minimal access to some local providers, their next available outpatient appointment. Perhaps the call agent is already affiliated with a clinical team, and we can search by a particular agency that the caller prefers and schedule them an appointment so they know that they've got something set up for the next day. It's already scheduled when they hang up the phone. So that's what we're striving for in terms of the gold standard of a crisis call hub. Someone to come to you is really this mobile crisis component. Now, again, not every community in the US has a mobile crisis unit right now. Some of those are co-located with emergency departments. Not all of them operate on a 24/7 basis. Some are more co-responder models where it's still a primary police response, but there's a social worker or a mental health clinician that's riding along with the law enforcement officer. The minimum expectation in the SAMHSA guidelines for the mobile crisis response is that there has to be a clinician that's making a response. Usually this is a two-person team. One of them at minimum needs to be a clinician. It's community-based, meaning, again, they're not co-located in an emergency department, and the expectation is that folks come to them, but that the mobile crisis team will go to wherever the person is in the community, just like 911 will, just like the ambulance will. If it's a kid in school, if it's a neighborhood street corner, if it's a person's home, that we come to you. And then also having those same kinds of connections, a warm handoff to a facility is needed. The gold standard, again, for mobile crisis, what SAMHSA is trying to push forward in terms of really elevating the level of care providing, is involving peer support specialists on those teams. I say it all the time, I'm going to say it again, peers are the secret sauce to everything we do in behavioral health, whether it be on the mobile crisis side, on the call center hub side, or even on the facility side. But having a two-person team with a clinician and a peer is just a dynamic duo to be able to engage that person. Having the GPS enabled technology so that you know where the person lives, how long it's going to take you to get there, can reroute you around any kind of disaster or traffic jam so that you can get there in a really timely manner. And then engaging police as a last resort. And this is really the game changer. It's diverting away from utilizing law enforcement resources, which should be focused on public safety, and having some kind of a framework. I know Michael will talk probably a little bit more about the framework that Behavioral Health Link uses. LA County is doing some really innovative work around this as well. You see places in the country popping up with having some kind of a framework for their mobile crisis teams of when to engage police. The idea is that the engagement of law enforcement should really be a last resort and in some very, very specific and often dangerous situations. The third component is really having some place to go. So this would be an alternative to the emergency department. These are warm, welcoming environments. We like to call them living rooms because they don't, like this is a picture of a facility from RI International in North Carolina. These are home-like environments. They're warm, they're welcoming, they're open, there's natural light, there's peer support specialists on staff. It's a much different setting than being in a hospital. Again, the SAMHSA guidelines outline a minimum set of expectation. Some of those are just accepting all referrals. We've all had the experience, those of you that are clinicians on the phone, you know the experience of saying, oh, well, they don't meet criteria because of A, B, and C, or you need to send them to the ED first for medical clearance before we'll take them, or oh, Michael Clay's, we had him last month and he's not welcome back. We fired him. So all these kinds of barriers to accepting people into care. So the minimum expectation is that all referrals are accepted. There is no requirement to go to the ED first. We find actually through RI International that a very, very small percentage of folks that present at crisis receiving facilities actually do need to go on to the ED for high blood pressure or a very real medical clearance. So having that be the first stop and letting the triage happen at the crisis receiving facility is really that minimum expectation. And then 24/7 staffing that includes medical staff and clinical staff. The gold standard, again, put forth in the SAMHSA standards, is really to have a dedicated first responder area. The idea here is that when there is a police drop-off, police can drop the person off to the receiving team, which is usually a peer. At RI, we like to say peer first, peer last. So the first contact that a person has, it's a very destabilizing time. The first contact they have is with a peer. And if we can hire a peer that used to be a guest at the facility, even better to be able to say, hey, I was a guest here once, and it's going to be okay. Now I work here. I've seen that happen myself, and it's absolutely magic. Also to incorporate intensive support beds, again, the live bed registry, and be able to have connections to ongoing care. And last but not least, the SAMHSA documents put forth a set of principles that should really undercut all of these. I think of it like a three-legged stool of the call center hub, the mobile crisis teams, and then the crisis receiving centers. There's got to be recovery-informed practice. There must be a significant role for peers in all three levels of care. Staff should be trained on trauma-informed care to make sure that they are not introducing any kind of secondary trauma. It's got to be zero suicide, safer care. Security and safety for all, the guests as well as the staff. And really robust first responder partnership. We cannot do this work in crisis care without having really strong partnerships with our local law enforcement on the ground and in the jurisdiction in which we work. On the Crisis Now website, I'm going to talk about that just a little bit. You'll see, I'm not going to go over this in detail, but it just is an example of, if you're interested in sort of the history, you can see that there are so many wonderful innovations that have happened over the years, starting in 1958 with what we think is the very first crisis hotline ever. We think it's D.D. Hirsch in Los Angeles from what we can tell, through CIT training for law enforcement, the introduction of this living room model, which was an alternative to these sterile hospital services. In 2005, the start of the National Suicide Prevention Lifeline, and a host of other innovations that have happened over really 60 years now that led us to, over here in 2020 with the SAMHSA guidelines coming out. So if you're interested in a little bit of the history, it's fascinating, and you can take a look at that on the Crisis Now website. Also on the website is a scoring guide. If you're interested in how your community, your county, your state is stacking up against those SAMHSA guidelines, there is a quick and dirty tool here to evaluate yourself on how your area is doing on a call center hub, how you're doing on mobile crisis outreach. Are you at the basic level 1 minimal? Are you level 4, getting close to some of those standards? And where are you at? If you're somebody that's participating in some of your state planning for building out a more robust and integrated crisis system, this might be a really good place to start. It'll help you identify some of the gaps in your system and come up with a plan to start targeting some of those. The other thing you can find on Crisis Now website is a calculator. I know that might sound boring, but it's really quite fascinating. You can enter in the number of people in your community, the number of crisis episodes you have, how many inpatient beds you currently have. It can give you another sense, again, if you're part of a planning group around, and you're interested in building out the crisis care in your area, this can really help you start to see maybe you have too many inpatient beds and not enough on a lower level crisis receiving facility. So when I talk about those levels of care, I mean like 23-hour observation or a 72-hour crisis stabilization. So these are lower levels of care, they're low cost. The goal of those facilities is really to get people a lot of wraparound support, get them stabilized very quickly, and get them back to their community. As we all know, a 2-week stay in a psychiatric hospital is extraordinarily destabilizing for folks. Having something like a crisis receiving facility, which you've got peers, you've got medical staff, you can do medication adjustments. It's a safe place. You can get a lot of support, get a breather, 72 hours, and hopefully be back with your family and your friends and back in your own home. The goal is to try to minimize that disruption that a person often faces. So the calculator is really interesting to help you start to see how many mobile crisis teams. If you wanted to move to a full Crisis Now model, how many mobile crisis teams would you need in your community? What's the price tag on that? If you decreased your number of acute inpatient beds, could the reduction in those costs actually serve to fund some of the other things you might want to do, like a crisis stabilization facility, adding beds, or adding mobile crisis teams? So I encourage you to go to the website and play around with that. And if you are looking for more resources or support, you can certainly outreach me, and there's lots of folks that can help walk you through that. Many states are already moving towards this more robust system of crisis care for various reasons. Washington State had a lawsuit several years ago on psychiatric boarding. They found that on average, persons with mental health crises that were sent to the ER ended up spending 3 to 5 days on average waiting in the emergency room for appropriate care. There was a lawsuit related to that, and it really forced them to take a look at building out that crisis system and doing things a lot differently. They ended up being one of the very first states to drop legislation specific to 988, which I'm going to get to in just a couple of minutes. State of Colorado took a hard look at that after the shootings with Columbia, Columbine, and Aurora. Focus on public safety. They knew they needed to do something different. They started realigning around one central call number and building out those other levels of care. Arizona was taking a look at this from a cost containment perspective. ED costs had gotten so far out of control because there were no robust continuum of care. And so people still kept, going to the ED to address these behavioral health issues. Today, Arizona has one of the most robust crisis continuums of care in the country. And Georgia was a huge innovator going back to 2005, making the decision to collapse what had been at the time 25, 27 different hotlines of various sources for various reasons into one number called the Georgia Crisis and Access Line, and then starting to build out the mobile crisis teams, statewide mobile crisis teams, and other levels of care. And they're still undergoing that work. They're looking at adding additional BHCC units and additional facility-based crisis. So you've got some exemplars across the country, and we see more states jumping on board every week. When states have implemented this full, what we call Crisis Now, which is this whole model of the three components, the no wrong door approach. This data is specifically taken from Maricopa County in Phoenix. And here's what we found, that this clinical fit to need that I talked about before, making sure that what the person needs, that they're getting care that's commensurate with what their need is, that increased sixfold. It reduced potential state inpatient spend by 260 million. In diversion costs, just in people not going to the ED, Arizona estimated they saved 37 million in avoidable costs, and reduce the total psychiatric boarding, that wait time in an ED for appropriate care, by a total of 45 years. And this is not to mention the drain on other community resources. So they also calculated that being able to have law enforcement officers drop somebody off at a crisis receiving facility in 5 minutes, 4 minutes or less, and get back out on the street doing what they do best, that saved an equivalent of 37 FTEs of law enforcement time, just having these other levels of care and places to go. Obviously, if an officer takes somebody to the ED and the wait time is 6 hours, the officer is waiting there with them. So a very different model, not only a huge cost savings, but in tremendous better clinical outcomes for the person being served, which is at the end of the day what we all want. Also on the Crisis Now website, you're going to find a link that's #CrisisTalk. If you're not signed up to get these newsletters, I would highly encourage you to do so. Every week there is a really compelling piece. If you want to start tracking what's happening nationally, it is the most exciting time to be in crisis care. So if you want to stay abreast of things that are happening, this is the newsletter to sign up for. Every week, there's new states that are proposing legislation around 988 that are there's highlighting innovations around mobile crisis, call center hubs, the use of technology, all kinds of really great stuff here. So I would just point that to you as a resource. So I'm going to switch gears now and talk a little bit about 988. Maybe some of you have heard about 988. This number will go live in July of 2022. Remember the old days, and I'm probably dating myself here. Dr. Druss and I were having a conversation about who could remember the Wayback Machine more than the other at the beginning of this webinar. I remember this. I was a child, but I do remember my mom having something that looked like this, that she wrote the numbers in for my brother and I, and she stuck it to our refrigerator. But this is the old days where things were fragmented. You had a different number for fire, you had a number for police, had a number for state patrol, your doctor. And of course, these were all very specific to where you lived. It wasn't statewide. It might have been your town or your city or even your county. 911 started to change all that. It collapsed all of these numbers and gave everybody one easy to remember number to call. And this was really a game changer for the whole country. Initially, when 911 was implemented, I believe it was late 50s, early 60s, there wasn't immediately available this response, someone to come to you in terms of police, fire, ambulance. But over time, those elements got built in, and that's where we're at today with our crisis services as well. I'm going to talk a little bit about what 988 is not. It is not a police response. This was one of the most read articles on the Crisis Talk website of all time. It's a really compelling article, and I'd encourage you to read it. Just a few statistics here. 10% of police activity are oriented towards behavioral health issues. It takes twice as long for police to resolve a mental health case. And 10% of the police budget ends up being for transport of persons with a mental health issue. The other thing that it is not is relying on hospital EDs for psychiatric care. This really disenfranchises individuals in crisis. I've said it a couple times already. So far, I'm just driving that point home. And this was another really great article on Crisis Talk that I'd encourage you to take a look at. As I said earlier, when a person with a behavioral health challenge presents in the emergency room, the average time that they wait for appropriate care is 3 days. Couple different time in Seattle. This was that Washington lawsuit I talked about. It was a 3-day. Atrium Health, North Carolina found a 40-hour average boarding time. And then there was another study that found an 18-hour average boarding time. That's just waiting without care in the ED. And that has a huge cost. Also, what it is not is putting up barriers to care. The idea behind 988 is knocking down all the barriers I've been talking about to care, such as, when you're calling around, oh, we don't have a bed available. This person, we had them here a couple weeks ago. They were pretty challenging. We don't want them back at our facility. This person's too agitated. They don't meet admission criteria, or we can't handle them right now. Or our acuity is too high at the moment. This is more of a substance use issue. You've got to go someplace else. So or we'll need a lab test. This is that medical clearance. All of these things are just barriers to care that historically have been designed to say no to people. And 988 is about saying yes to people. It's about saying yes to everyone, every time, anywhere. So that is what it is. Anyone, anytime, anywhere. We used to say there's no 911 for a mental health crisis. Now there is. It is 988. So we will have 911 for medical emergency. Now the marketing campaign for this has not yet begun. SAMHSA will be taking the lead on that. Of course, there's a lot of community education that needs to go into when do I call 911? When do I call 988? But it really is going to be a game changer in terms of accessing immediate care for persons in a behavioral health crisis. How this works under the hood, you guys are probably familiar right now with the National Suicide Prevention Lifeline, the 1-800-273-TALK. You may know that when you call that number, it routes to the, it uses your area code. So my cell phone is a 602 area code, that's Phoenix. So if I call 1-800-273-TALK from my cell phone, it's gonna ring at the call center in Phoenix, Arizona. If I had a 404 area code and I called 1-800-273-TALK, it's gonna ring here in Georgia at the Georgia Crisis and Access line. So what will happen come July is that 988 will be turned on live. And when somebody calls 988, it's still going to point to the National Suicide Prevention Lifeline and then be automatically routed to the center closest to you. The geolocation piece is still being talked about. Is it still going to be based as it has been on area code, or will there be a geolocation capacity much like 911 has? So there's still a few things that are in process there. But the idea is to start to develop a comparable response on the mental health side that is comparable to what we have on the 911 side. So we have this emergency communication center. We have multiple 911 centers across the country. They dispatch emergency medical or law enforcement, and then they have emergency room as a place to take folks to. On the other side, we have the Crisis Call Center Hub, the National Suicide Prevention Lifeline, which is now 988. And then we have 3 potential outcomes there: a mobile crisis team instead of an ambulance, a peer warm line, connections to outpatient care, live bed registry, being able to place somebody in a crisis facility receiving center if needed. So really the idea here is driving home the idea of parity, that we want the same type of urgency and immediate response for a mental health crisis that we have all come to expect on the physical health side. We do know that many mental health crises are life-threatening, and the same kind of response, resources, immediacy is warranted on that side as well. So at the end of the day, that's what this is all about. In terms of volume, there's some pretty steep predictions of volume. Right now, the National Suicide Prevention Lifeline receives about somewhere in the neighborhood of 3 million calls a year. There's another 13 million calls that go to all those local county numbers. You know, a lot of jurisdictions have their local number that they promote, and there's 13 million going there. We estimate that there is about 240 to 250 million calls that go to 911 annually. And a conservative estimate is that 10% of those are actually mental health related. That would mean that 24 million calls to 911 are actually behavioral health related. And what that means is that we are about to have 40 million plus annual crisis calls. And it will be a slow migration, right? As people learn that they have an alternate to 911, but in some estimates that call volume is expected to double. Michael's going to talk a little bit more about that specific to Georgia as well. I believe this is my last slide. Again, just want everybody to be thinking about crisis care as that full continuum of care. So if you think about community-based services, trying to resolve folks the right care at the right time, with the appropriate level of service. So this clinical fit to need, matching people up. You've got to have a full continuum of care, right? You can't have 40 million calls coming into 988 and not have anywhere for those folks to go. So thinking about it as a continuum, having a peer warm line, a crisis clinical answering service, definitely having this call center hub that's available through text, chat, app, however folks want to contact you, increasing accessibility there, being able to schedule 24/7 outpatient appointments any time of the day or night. The caller does not have to wait until the facility opens the next morning. The call agent should be able to schedule that for you. Hospital rapid response teams, community mobile crisis, and so forth into the facility base, the 23-hour observation, short-term crisis stabilization, and then at the very high end of the spectrum, the acute care inpatient. This is the gold standard for what we want to have in every single community, so that we make sure we have every level of care and that we can match the person's need. And it's not just an all or nothing. It's not just a good luck with that, hanging up the phone at the call center, or we have nothing else in this middle here, so we're going to have to send you to the ED or a psychiatric hospital. So with that, I will hand it over to Michael Clays. And as Dr. Dress said, Michael is the Executive Vice President at Behavioral Health Link, and he's going to talk us through what we do here in Georgia.
Thank you, Sue Ann, for great information. Hi, everybody. Just a quick time check. We have a hard stop, I'm assuming at 1 o'clock, because I want to make sure that we leave room for questions, because a lot of great information there. Emily?
Yep, that is right. We do have a hard stop right at 1 o'clock.
Okay, thank you very much. So you've heard about this national vision, and indeed parts of what Sue Ann talked about are in place in various states and various communities. I'm proud to say Georgia is, for a change, maybe farther ahead than other states. As she indicated, we've been operating the Georgia Crisis and Access Line since 2006, prompted really by the Katrina evacuees coming to Georgia, and the fragmented system that existed there was very much the impetus for the state to consolidate all of those call centers run by local CSBs, behavioral health providers, into one number. Prior to joining Behavioral Health Link, I served as executive director of behavioral health services at Grady Hospital in downtown Atlanta for 10 years. And so I'm very familiar with the individuals being boarded in the emergency room, and the amount of investment that Grady Health System made in serving that population is really exemplary. And we ended up creating a dedicated, when I started, people were put in small rooms and more or less tried to keep safe as much as possible. And the hospital, through a fundraising effort, received about $76 million from Bernie Marcus, the founder of Home Depot. And one of the first things they did was built a psychiatric emergency room that allowed for 24/7 psychiatrists and social workers to do an assessment and make a quick disposition. So the length of stay went from days sometimes to just a few hours. But we did have a 23-hour observation unit that individuals could go to if they needed more care. And of course, we were able to discharge people to the communities. And so we also had partnerships with Behavioral Health Link, where when in the city of Atlanta, if someone calls 911, the 911 dispatcher is determining if it's a mental health crisis. And if so, they are either transferring the call to the GCAL, Georgia Crisis and Access Line, or they are initiating a partnership between a mobile assessors from Behavioral Health Link and a paramedic from Grady. That was put in place because Grady wanted to get upstream to be able to serve people in the community and defer individuals coming to the emergency room when assessments could be done in the community. And lots of great research out there on that project, which started back in 2014 or 15, the cost savings and the high percent of people kept out of the emergency room because of that combination. And so, Joanne, if you could go to the next slide, please. Thank you. So as Joanne indicated, the Crisis Center hub really is this idea of air traffic control, where you've heard and think of the 911, someone to call, someone to go see them as the mobile teams, and then some place to go. The state of Georgia operates a network of crisis stabilization units, and as we'll talk about in a second, the GCAL operates the bed board, which allows us to see the capacity of those facilities. So when someone shows up in the emergency room at a hospital like Grady, we know where available resources are statewide, and obviously trying to facilitate an admission to the closest location for those individuals. But as the slide says, it's not just telephonic. We're taking, I think back in 2015, Behavioral Health Link started taking text and chats, which are obviously much more prominent among people who might be younger, and so we certainly get a lot of those. Next slide. Okay, so yeah, I think that just kind of covers what I already mentioned. I will say last year we had 275,000 calls came into our statewide crisis and access line, and out of those, we'll look at some numbers in a second. About 15,000 of those ended up in a mobile assessment, and so our ability to resolve crises over the phone, to help either get someone an appointment, to de-escalate the situation, or to dispatch a mobile team to make a further determination is really important there. And all of that is underlined by software that really would be our secret sauce that helps us do the dispatch mobile. The mobile teams have an app that the call agent can do a dispatch from the call center and activate the mobile team that is closest to the person in need of help. So that information can be tracked in terms of both safety and response times. As I mentioned, this real-time crisis bed management is just so important. There's such a scarcity of beds in many states, and yet at the same time, beds are empty. And so this has really helped match the need of the individuals with the proper bed. Obviously, beds can be segregated by gender, right? And so, or child and adolescent or adults. And so we have logic that helps us identify based on the person's demographics where exactly the open bed would be available for them in that particular region statewide. And then there's dashboards associated with that, which help state officials be able to identify how well their provider network is doing in terms of receiving individuals and also the length of stay. So you can kind of see there a visual of all of the things that we do in Georgia, kind of the real definition of a crisis hub, which is, again, much more than a national suicide hotline that's vital to our nation, but this is, again, a step beyond that. So you can see here, again, like I've mentioned, about 90% of the calls that come into our call center are able to resolve over the phone, meaning either the person got their needs met through a conversation or a referral was made for an outpatient appointment. Maybe referrals were made to a peer warm line. We rely very heavily on those or other ancillary resources. And that if a mobile team is activated to go out and perform an assessment in the field, 75% of the time they leave with a plan, and that person remains home. They may follow up with a existing provider, they may go see a new provider, but these are all cases historically that law enforcement would be involved, and they're going to take somebody to either to jail or to the emergency room. And so the fact that we're able to resolve these appropriately in the field is just wonderful for individuals. And so, like I mentioned, the importance of a 23-hour observation unit is vital. You know, we converted at Grady standard crisis stabilization beds, build it, and they'll come to which we had a length of stay of 5 to 7 days because we had so much volume. We needed to think differently, and so we converted those beds to 23-hour observation chairs, if you will, and really re-engineered our workflows so that medication, therapy, everything that would happen during the first couple of days of a hospitalization were happening in hours instead of days. And 50% of the time, we were able to discharge individuals from that length of stay as opposed to admitting somebody to a bed just because we had one. So that's a vital component in the toolbox here. And then, of course, individuals might need longer stay, 5 to 7 days in terms of crisis bed and inpatient care. All right, I made it with 5 minutes left for conversation. Thank you, everybody, for your attention, and I'll turn it over back to Emily.
All right, thank you so much, Michael, and thank you, Sue Ann. We've now reached the Q&A portion of today's webinar, so everyone, please feel free to submit your questions by typing them into the Q&A feature. I think that we already have 2 questions in our Q&A function, so I'll go ahead and read the first one that we had submitted. And that first question is, will 911 reroute calls safely to 988 as appropriate?
So this is the uncharted territory right now, and I'm on the statewide work group interfacing with 911. And again, every state is a little bit different. In Austin, Texas, they're asking in the city of Atlanta. So first of all, in Georgia, there's 154 different 911 centers. So unlike the Georgia Crisis and Access Line, all of them might have a different response. They are obviously evaluating right now the liability issues of transferring a call versus sending out an ambulance or law enforcement. And we're actually working together on scripts to help them decipher which decision to make. So we're in the early stages of that. And hopefully the next few months, we will be able to have that finalized. And so that is a great question, because Dancing with 911 is, this whole thing is intended to help take volume off of 911. But they've got to be willing to transfer the call. I'm not sure I understand or could answer that next question. So if somebody maybe wanted to, or Sue Ann, if you might be able to chime in on.
Yeah, on that one continuum of slide, there was peer warm line, clinical answering service. And, right now in this country, we have a lot of different ways that we, answer the phone. It's not part of the SAMHSA guidelines, and that the gold standard there is really the call center hub. But the clinical answering service, this is something that a lot of communities use. For example, outpatient clinics after hours might hire a clinical answering service, so that if one of their clients has to call after hours, somebody picks up the phone and can talk with them and maybe schedule an appointment. They're not really in the business of trying to de-escalate crises, but it's a contact for folks. So it's one of these sort of lower level, when we think about all the services that are available, from a peer warm line to an answering, like an after hours answering service for doctors' offices and outpatient clinics, but then really getting into when people are in that behavioral health crisis, we're really looking at the call center hub. All of these things have a place. All of these services have a place in the continuum. But we do think we'll start to see some of that shift and change as more people, as 988 becomes more, part of our everyday language, just like 911 is, we'll probably be seeing a lot more calls just heading that way. So that's what that.
Thank you. And in Georgia, the GCAL number is frequently provided by outpatient providers and clinics. And so I just want to mention before we wrap it up, our call volume due to 988 is expected to increase 5-fold over the next 5 years. I'll do a shameless plug. We are hiring. We need qualified people, and the state, recognizing that this volume is increasing, we want to have caring, compassionate, and competent staff to be able to do this work. And we've gotten authorization to hire people outside of Georgia, which has not been the model. So that just demonstrates the need that's there. And I imagine the states that you all are in, if it's not Georgia, the same dynamics apply. I did put the link of behavioral health link in the chat. If there's any interest of you or your colleagues, please check out that link to our career site.
All right, thank you so much, Sue Ann and Michael, for your presentation and for answering our questions. That is all the time that we have allotted today for questions. So we're going to move on into the evaluation portion. The Southeast MHTTC would like to thank you for your participation in today's webinar. We value your feedback and invite you to evaluate our event today. Please complete a brief SAMHSA required survey by visiting the link presented on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events. Afterwards, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There, you'll have the opportunity to download a certificate of attendance for your records. Allow about 5 to 10 seconds for your browser to redirect you. Again, our center appreciates your participation and feedback. Michael and Sue Ann, we so appreciate you coming and giving this presentation, answering our questions today. Please, everyone, visit our website to learn more about our center and upcoming events. And that will conclude today's webinar. Thank you again, Sue Ann and Michael, for such a wonderful presentation.
Great. Thanks, everybody.
Thank you very much. Everybody have a great day.